Welcome back to the American College of Surgeons Bulletin Brief from the front lines. Today, we're going to be speaking with three of my colleagues at Cleveland Clinic, Florida. So I'm serving a dual role in my usual function as the MC interviewer, but also as a participant in the recent American College of Surgeons Quality Verification Program visit by the ACS. So I'd like to introduce our three guests today, Dr. Manny Lomenzo. Dr. Lomenzo is the director of the Department of Clinical Research at Cleveland Clinic, Florida Weston. He is vice chair of the Department of Surgery and associate program director in our general surgery residency program. He's been serving as our surgical quality officer in our digestive disease center, which is colorectal surgery, general surgery, bariatric surgery, breast surgery. Dr. Carla McWilliams. Dr. McWilliams is probably the busiest person in all of our Florida region, given that she's chair of infectious disease. And given the pandemic, she's been absolutely overwhelmed with her clinical responsibilities, but done a spectacular job, not only as chair of infectious disease, but as the Quality and Safety Regional Medical Director of Occupational Health. So Chief of Quality and Safety, as well as Medical Director of Regional Occupational Health. And lastly, but certainly not least, it always falls to somebody who's not a physician who really does all of the work or much of it. And Nadia Cuff is our Senior Director of Quality and Regional Clinical Innovation. So welcome to the ACS Bulletin Brief. I'd like to start out directing a question maybe to Carla, given that you're a physician but not a surgeon, and to talk about your familiarity or lack thereof with the American College of Surgeons quality programs prior to this visit.
Thank you, Dr. Wexner, for having us to talk to everyone today. So yeah, to your point, we did not know a whole lot about the ACS program, but it was wonderful to be a part of it and to learn some of the things that you all are looking at from a surgical standpoint in terms of quality verification programs.
Thanks very much. Nadia, tell us about some of the other quality programs in which you've helped prepare for surveys, whether they're regional, state, federal entities, or other verification programs prior to this one.
Our departments are focused on preparing our caregivers to be in a constant state of readiness, whether it be a Joint Commission triennial survey, or if we have a visit from our local Florida Department of Health in regards to any EMTALA violations or any other regulatory standard.
Okay, so certainly a veteran of many of these programs, many of the site visits. So to ask you to give us your thoughts on what was the amount of work required for this survey versus some of the others in which you've participated?
The pre-work was actually a lot, specifically because we had to gather pre-review questionnaires for each specialty within Cleveland Clinic. We had a lot of support from our key leadership, or local leadership here in Weston. So although it was quite extensive pre-work in regards to the amount of information, it was actually very beneficial to get their input.
Dr. Lomenzo, you're both a fellow of the college as well as somebody who you were responsible for coordinating the quality verification program. I kind of ask you the same question. You also participate in MBS QIP and other programs. How easy or hard was this, relatively speaking, to go through this mini visit?
Thank you very much, Dr. Wexner, for the opportunity of this interview and to allow me to participate to this process. This was a process new to me, although, like you said, I've been participating to other quality initiatives in the past with the ACS, including NISQIP. This is a much more comprehensive program. In fact, this review goes across every single surgical specialty in the hospital. So it really covers all the subspecialties, which we don't know much about usually. starting from urology, orthopedics, ENT, plastics, and so forth. So this was a much more in-depth analysis of what our quality of resources and organization is within our institution.
Yeah, and perhaps let me just let you continue along that line of thought, because you said areas with which we're not necessarily familiar, like urology. In the standard university or even previously clinic structure, one would have a medicine grouping and a surgery grouping, whether that's called a department or a division. Maybe you could just explain a little bit about the way we work at Cleveland Clinic.
Sure. And I think that's a great point, because our structure is a little bit different than other institutions, as we are organized by centers based on disease groups. And in fact, for DDSI, the Digestive Disease Institute, within our institute, we also house GI, so a medical specialty. So that, of course, is the same across the other treatment lines, especially for the surgical subspecialties. The particular point persons and leaders that are requests from this review might not be necessarily present in the definition that the reviewers were looking for. However, we realized after our in-depth analysis that these particular leaders existed in our institution, but they had different names and different roles. And some of the roles were actually covered by higher people and colleagues, such as the CMO of our hospital, for instance, or chief of staff.
Thanks very much, Manny. Let me ask Dr. McWilliams, the review, any review really, is both to prove what you do to the reviewer, but also to learn from the review, and whether that's the Commission on Cancer, MBS QIP, NISQIP, National Accreditation for Colorectal Cancer. Could you tell us some of the things that you learned, number one, in preparation for the review? As Manny says, maybe you kind of turn over something and say, wow, I didn't know that was there. And then secondly, things you learned from the review itself, during the review.
Sure. Well, first I want to comment that I think most physicians, including students, residents, fellows, and maybe some people who are in practice, may not necessarily realize or understand and comprehend the amount of time, effort, and data gathering that goes into a hospital-based quality and safety program. We collect a tremendous amount of data for public reporting across all realms of the hospital and the institution. And that is really what drives patients seeking care, is quality outcomes, patient experience, and so on and so forth. Surgery is a part of that. There's many others, as Nadia had commented on earlier, Joint Commission surveys. We have local regulatory bodies that we have constant site visits for, and we have to be in a constant state of preparation and readiness. Specifically with surgery, I think that what I learned is that there's still an opportunity to look at a lot of different surgical metrics that aren't necessarily mandatory reporting. We obviously look at SSIs, and we look at hip and knee replacements and infection rates, and report on all of those things. But there's still many other surgical specialties where we don't necessarily do that right now, but we really should. So part of that learning opportunity is really to understand that across all the realms of surgery, we need to track, report, and look at quality outcomes to drive good care.
Excellent. And it's important, as you mentioned, that it's across the institution. It's not just surgery, obviously, although this program is specific, as it were, to surgery. So towards that end, are there any specifics that you might think about changing in our methodology, our data collection, our reporting, based on what was told to us by the ACS after the visit?
I think there's always an opportunity to improve how you do things across your institution, even specialty specific. And the opportunity there is to meet with the leaders in each of those departments to determine what are the real outcomes that you want to look at that drives quality care and patient satisfaction. And then based off of that, you can mold what data you need to collect to be able to measure your outcomes.
Thanks very much. Nadia, you did a lot in preparation for the review, dealt with the ACS staff, and for those listeners and viewers who are contemplating undergoing the quality verification program visit, what was it like dealing with the college staff in terms of responsiveness and ease of communication and clarity of instruction?
They were extremely helpful, very accessible. Every single time I had a question, there were some materials that they did send. They had very good instructions. One of the recommendations that I would give to any organization contemplating whether or not to participate is that this is an extremely beneficial process for any organization to review their internal processes. It allows us to gain a very clear picture of our current state and to build upon our existing infrastructure to maintain safe quality of care for surgical patients. The ACS staff were very, very, very nice. And as I said, extremely helpful whenever we had any issues and needed additional clarity on any of the specific standards.
Thanks very much. Manny, let's turn back to you and ask a question, because now we've heard from both Nadia and Carla that we can meet with leaders, speak to leaders, things have been learned. You're the person in surgery who has to now have those conversations with individual surgeons about change to improve metrics, to improve outcomes, which are then measured, obviously. How do you go about having those conversations? Again, we have a lot of surgeons listening who are in leadership, and how do the leaders then convey the lessons learned during a self-analysis process like this and during the digestion of what's been told by the external body, whether it's the ACS or any other organization? How do you communicate that information in a way that somebody is engaged and wants to participate?
So the communication started initially, obviously, unofficially in preparation for the survey by discussing with our colleagues what their system was in the different centers, realizing that there were some gaps that needed to be filled. And then after the review and with the addition of the recommendations from the ACS, all these gaps and opportunities and now are brought back to leadership, and they will start by involving every single surgical champion for different centers in higher level discussions, and to try to filter down the information to the single departments. So certainly this was very helpful to understand not only at the center individual level, but also the higher level of administration.
Great. And you're speaking to people as a surgeon. Dr. McWilliams, when you have these conversations with people, do you have any kind of tricks to give our leaders who are listening as to how to ensure compliance?
You know, it's hard sometimes to hear negative feedback, right? Because we always want to believe that we're always being perfect all the time. But to be humble, we're not. There's always something that we're going to do better. And so the way that I approach this as the quality leader for a hospital with any type of leadership individual that I'm talking to is there's always something we can do better. That doesn't mean we're doing things wrong now, but it means that there's an opportunity or a gap that we've identified that we need to fill so that we can excel and do even better than we're already doing. So that's kind of the way I look at it. The other way I look at it too is we never, ever, ever approach this in a punitive fashion with anyone. You know, we're all human. We work in a very, very complex healthcare system, and there's always going to be an opportunity for system failure, even if you have every process in place that you need for safety outcomes. And so that's where the term high reliability within our organization comes into play as we speak to leadership. We have a very systematic way that we look at things, whether there is an individual failure or a system failure somewhere along the lines as we go through cases where there's opportunities for improvement. So that's my long-winded answer for how leadership on the call can really look at this. We have to look at this in a way where if we had our mother or a brother or a sister coming into our hospital, we would want them to get the best care possible. And if we identify a better way to do that, then we should just press on forward and make it happen.
Do you think that the information gleaned from the QVP process will facilitate those conversations?
I think it will, because to many of the points that were made by Nadia, as well as, Dr. Lomenzo, is we identified areas that we weren't necessarily looking at every day that we should be looking at every day. And we need to engage leadership within all of those specialties. I don't necessarily know as an infectious disease doctor what a plastic surgeon looks at for their outcomes, versus an ear, nose, and throat doctor. So that's where you engage your leadership at every department level to determine what your standards really should be so that you can measure them and then drive change within your organization.
Excellent. Really, really well summarized. Thank you. Just before we close, I'll give each person a chance to add any remarks, not obligatory, but if you have anything else you might wish to add about the process, start with Nadia.
Our experience was extremely beneficial. It allowed us to comprehensively review our current processes surrounding surgical quality. It also allowed us to rate our ability to standardize care, and also to contemplate how we meaningfully use data.
Dr. Lomenzo.
This was a great experience, an eye-opening experience, because what we do every day that we don't realize should be done sometimes in a different way or organized in a different way to make sure this remains a patient-centered initiative, but physician-led, because we have to obviously make sure that we are the leaders and we understand what is important, and also have a team approach. And that's exactly what this process taught us. Get together with our team, getting to know the team that we not necessarily knew before, and move forward and try to improve quality all around.
Thank you. And lastly, Dr. McWilliams.
Yeah, I'll echo all of the same things and then just comment that there's a lot of things in the surgical subspecialties that aren't necessarily obligatory reports right now, but there probably at some point in the future should be. And this was a great opportunity to identify that across all those surgical subspecialty realms that we need to, like Dr. Lomenzo said, talk to our surgical leaders and gather what those metric points should be, so we can measure them and drive change.
Thank you very much for your insight, your reflection, your time, your expertise, both today during our conversation, as well as prior to and during the QVP visit. Much appreciated.
Thank you.
Thank you.
Thank you.